Welcome to the final explainer of our four-part series. This episode is based on gaze stabilization training, principles and prescription, mechanisms, exercise library, and outcome measurement, published by Australian Dizziness clinics. So, if you've been following along, you know we've been pretty deep in the weeds of vestibular rehab. Today, we bring the whole thing together. We're going to lock down exactly how you measure success and, importantly, how you handle those incredibly frustrating patient plateaus right on the clinic floor.
Okay, let's dive into this. Picture yourself at your desk, right? It's the end of a long clinic day, and you're writing up discharge summaries. What actually separates a highly effective, memorable 6-week gaze program from one a patient just quietly drops? It's the data. Handing a referring physician a note that says, patient reported feeling better, kind of means nothing, right? But handing them a document showing a solid one-line dynamic visual acuity gain and an 18-point DHI drop, now that is undeniable. That's a definitive, objective result that builds your reputation and validates your patient's hard work. So here's the pathway we're mapping out today. We'll briefly look at the value of objective data, break down specific outcome tools in MCIDs, tackle progression in plateaus, cover those crucial refer onward red flags, and then bring it home with our series wrap and key takeaways. All right, let's start with part 1, the sheer value of having objective data. A 6-week gaze stabilization program really needs hard, measurable outcomes, not just guesswork. The literature is super clear here. Patients want a number, refers absolutely want to see a change, and you, the clinician, need objective evidence that the dose you prescribed is actually working. Imagine a patient fighting through that initial wave of dizziness. When they understand the retinal slip rationale and they physically see their numbers improving on paper, well, their adherence just skyrockets. Objective evidence is literally the foundation of patient buy-in. Moving on to part 2, let's look at the actual outcome tools and MCIDs. Now, what's really interesting about this is the exact minimal clinically important differences, or MCIDs, you need to target at that 6-week mark. For dynamic visual acuity, a one-line gain at retest is a meaningful functional response. For the Dizziness Handicap Inventory, or DHI, an 18-point reduction is your published MCID. Looking at the ABC scale, you want a 10-point improvement to show they are sitting under that 67% falls risk threshold. And hey, if your clinic has the equipment, the functional head impulse test, measuring visual acuity during the impulse is absolutely your gold standard here. To track these metrics properly, your retest cadence is everything. You want to bring patients back every 4 to 6 weeks. Why that specific window? Well, measurable VOR gain changes can actually be detected pretty early, but the subjective benefit, the functional stuff the patient actually cares about, that usually doesn't emerge until somewhere between weeks 3 and 6. So this specific timeline dictates your next move, telling you exactly whether you need to escalate the dose, maintain it, or refer them out. But there's a huge catch. A 6-week outcome is completely functionally useless without a rock-solid day 1 baseline. You've got to document DVA, fHIT, DHI, and ABC at session 1. If you don't know exactly where they started, you have absolutely no way to prove your intervention worked 6 weeks down the line. It's the crucial difference between hoping they improved and knowing for sure that they did. Let's move to part 3 and see how this builds into progression and plateau triggers. This is that critical middle phase of treatment. It's the exact moment where patients hit a wall. And honestly, clinicians often get stuck too. Looking at a standard timeline, week 1 is baseline testing, week 4 is your first critical retest. Now, by week 6, for unilateral hypofunction, you'll typically see a plateau. The patient comes in and says, yeah, I'm just not noticing changes anymore. This is your cue to shift the category. And by week 8, if progress is completely flat across 2 consecutive reviews, that is your hard trigger for a referral. So how do we actually beat that week 6 plateau? The biggest trap is just telling the patient to do more reps of the exact same exercise. Actually, scratch that. Doing more reps is useless here. A plateau means you have to escalate a specific dimension of the exercise. You need to push the head velocity right until the target just begins to blur. Or you might switch to 2x2 viewing, add a busy background like a checkerboard wall, or introduce cognitive dual tasking. You absolutely have to change the stimulus if you want to keep driving that cerebellar plasticity. You'll also run into this really specific scenario. What if you get an objective DVA improvement, but absolutely zero DHI symptom improvement, meaning they are improving biomechanically, but not functionally? This is a massive clinical insight. It means you stop pushing the VOR drill itself, and instead you escalate the standing or walking layers. You've got to take that newly improved gaze stability and integrate it into their functional postural control. Which brings us to part 4, when to refer onward. Because let's face it, despite our best efforts, not every patient responds.
You need clear algorithmic decision branches for when they stall out. The rule here is absolute. If a patient is 8 weeks flat, meaning zero change across 2 consecutive 4-week reviews, even with perfectly dosed exercises, you must refer onward. You're specifically looking to refer for a vHIT and central imaging to see exactly what we're missing. When they aren't responding, your brain needs to instantly run through this checklist of underlying diagnoses. Are we looking at a missed central event? Could it be a schwannoma? Is there an overlapping vestibular migraine that's blocking adaptation? Or maybe it's severe vestibular anxiety. If it's anxiety, you need a low-dose, slow-ramp protocol and a direct referral to clinical psychology for cognitive behavioral therapy.
So, the crucial point is this. There is a red flag safety contraindication every physiotherapist simply must memorize. If a patient suddenly reports new spontaneous vertigo, new neurological symptoms, or a sudden change in their hearing during the program, stop. Stop the program immediately. You must refer them for a medical review to rule out acute decompensation or sudden sensory neural hearing loss before you ever even think about resuming. That is not a plateau, that is a hard stop. Finally, part 5. Let's wrap up the series and hit our key takeaways. This concludes our 4-part series on gaze stabilization training. If you take literally nothing else away from our time together, let it be this core message. VOR adaptation is retinal slip-driven, it is frequency-specific, it must be dose-graded, and it is retested at 6 weeks. If you are not producing a controlled retinal slip error signal, you are simply not producing cerebellar plasticity. It really is that straightforward. To make this totally actionable on the clinic floor, here are your 3 steps. Step 1, retest DVA, DHI, and ABC every 4 to 6 weeks. Step 2, remember a plateau triggers a category shift. So push velocity, use X2 viewing, or add busy backgrounds. And step 3, if they are flat at 8 weeks, refer them out for vHIT and central testing. And this brilliantly illustrates the caliber of resources available. Visit AustralianDizzinessClinics.com. You can get the full literature review and the cheat sheets we've been using right there. Subscribe and rate. So before you head out, I want to leave you with one final thought. Looking at your very next patient, how are you going to upgrade your baseline testing tomorrow morning? Take that into the clinic with you. Thanks for joining me on this deep dive.